Hello, good afternoon, good morning, good evening, again, depending on your continent. So welcome to this second day of this IRCAD webinar, which is focused on rectal surgery. I am Bernard Allemagne, I'm a foregut surgeon, and I will try to guide a little bit this webinar with the support of two moderators who in fact are colorectal surgeons, two fellows. The first one is Madi from Maastricht University Hospital. And the second one is Nariaki, who is coming from Japan, from Yokohama, the General Hospital in Yokohama. So these are the one who will probably guide a little bit the discussion, but being a foregut surgeon, not knowing anything about rectal surgery, I will tease you a little bit during these different steps of the webinar. My pleasure to have a very nice faculty. You know that yesterday we had also a very nice faculty and a lot of participants addressing the key steps of TME, addressing laparoscopic TME, and also some issues like colostomy, the best anastomose, etc. And so we continue this topic while we will cover the question of robotic. We have a fan of robotic, Armando Melani from Brazil, Rio de Janeiro, and also the director of IRCAD Latin America. We will have a very promising person from Amsterdam, a colleague from Belgium, Roland Pens, will talk about all the management of the problems, intraoperative problems, postoperative problems, because he has very interesting visions regarding the management of the patient. And finally, we will address the issue, the concerns about transanal TME, because you know that in some countries in Europe, this is not authorized anymore. And in other countries, I think like in Holland, it's only reserved for trials, clinical trials. So there are a lot of questions around TaTME, and there we have an expert, Masaiki Ito from Japan, who is really a brilliant surgeon. So he has a very fundamental view and analysis of the TaTME. So very nice program. The course of this session will be that each of the speakers will give the speech. Then afterwards, we will stop to have a discussion. Discussion will be moderated by Madi and Nariaki, and we will go to the audience because the audience is allowed to ask questions, to write questions. So we'll try to interact with our participants. And that will be for each of the speakers. And finally, we have a final discussion, again, reviewing all the questions of the participants. So for the participants, do not hesitate to write your question. We have the team that will look at all your questions. At some point during the discussion, we will ask some of you to ask orally the question, and you have just to push on a button, and we will connect you online to ask your question to the experts. So this is the way to do. We're going to start with the robotic, the role of robotic, and what are the key steps of robotic TME. So we can compare a little bit with the TME, laparoscopic TME that we discussed yesterday. So my pleasure to introduce my good friend, Armando Melani from Brazil. Thank you, Armando, to being with us.
Thank you very much, Bernard. It's a pleasure for me being here and discuss a little bit about robotic TME technique. And well, once we have a short time, I'm going to jump directly into my presentation. Well, the idea is, of course, when we start the surgery by itself, it's very important to understand the trocar's placement and the docking. This is what we do for XI, so we can switch the camera in between the arms because all of the trocars, they work in the same size. Is a little bit different than SI system, the system that we have in the majority of the hospitals in Brazil, where we have to work with a fixed camera, and usually it is located at this blue arm, and then we have arm 1, 2, and 3. So and this is how we dock the system using SI system. I believe that TME starts, in fact, the dissection of the artery. So we will start this video starting our dissection a little bit below the artery. Our aim is to get the origin of the inferior mesenteric artery. I'm gonna jump a little bit here because of the time. So once we have the artery, we divide the artery. I have an assistant to put the clips because with this idea, I can save one arm and they can decrease the cost of my surgery using the assistant to use the clip. And then we will detach from the meso, the branch of the nerves. And from there, we are gonna go a little bit medial to lateral, detaching the meso. And we go further inferiorly, working a little bit in the medial to lateral size, but a little bit different than laparoscopy. We stop this dissection, and then we switch for lateral dissection. The robot facilitates, and how we angulate our arms and the tip of our instruments facilitate this type of dissection, as you can see. I have a 20 minutes video, so to keep in time, I'm gonna speed up this part of the surgery. And we detach laterally the mesocolon, as you can see, just using pure energy as a cut. No advanced energy device. And then we start the mesorectum by itself. I like to start at the left side. As you can see, we establish the embryological plane coming from the Toad's fascia. And this is the way that we like to do this. The standardization is a little bit different than the conventional TME, as was taught for us by Eric Houllier, the way that he standardized. And I believe that using the robotic tools, we have to work in a different ways. It's very funny because from this robotic way to do TME, we learn a little bit and we improve our laparoscopy TME also. You can see the nerves at the left side. As you can see, everything is pure energy. No advanced instruments, good traction, and the surgeon has all the control. Well, once I get the promontorio, I'm gonna switch to the other side now. And you are gonna be able to recognize this is a pretty familiar vision, very close to what we see in laparoscopy. We dissect a little bit at the right side. Another thing that usually we push the rectum, and with the robot tool, we grab the retroperitoneum space. And so you can change a little bit the way that you deal with the instruments and the tissue, because you can do a very gently traction. You have all the control of the instruments and all the degrees of freedom of the tip of your instrument. So you are able to do something that you are not able to do by laparoscopy. And this is one of the advantages of the robotic tools. I'm gonna jump a little bit further, just saving time. We go a little bit posterior, not too deep, because usually we believe that we should do this dissection mostly using the working at the sidewall space. So not as we used to do in the past, posterior very deep, and lateral, and then at the end anteriorly. So I'm gonna jump a little bit here. We go very early in the anterior wall of the rectum, above the peritoneal, the reflection, 2 centimeters. And we are able to open this space. And it's very nice to understand when you communicate. In the past, we used to go lateral or posterior to anterior. And you see that in this, using the robotic tool, it looks like the plane is here. But when we switch our strategy and we come from anterior to lateral to communicate everything, everything changes, and we are able to understand better these planes, even in a very obese patient like this one, and even with a patient with a previous chemoradiation therapy. So as in this case, I have an assistant in a suprapubic port. He's using just suction, as you can see. I have the third arm doing anterior traction. I like to use the Cadier forceps for my third arm. This is a personal preference. Very early, we are going to detach the vesicles. In this area, I'm working with a 30-degree scope. At the beginning of the procedure, we work with a 30-degree scope. You see gently traction. This is very important, and unfortunately, we learn with our mistakes because you are able to do a huge traction. But if you do that, you are going to tear the nerves, and you can have problems. Now I'm switching the camera for 0 degree. It allows me to have a better view, a direct view. And now I am communicating anteriorly to the lateral side at the left side. You see, my forceps is working with an L shape. So I am able, I don't need to grab the tissue as we used to do in laparoscopy or transanally. I just push the tissue using this L shape of my instruments. We are respecting the plane. Even though sometimes we can have some adhesions caused by the radiotherapy. And you switch from the left to the right side. This is what we do. Communicate anteriorly. And I'm using here SI system, what does not allow me to change the camera because sometimes, as Amjad Parvaz used to advocate, using XI system, you are able to switch your camera position, and then you have a better view for the right side. No advanced energy here. No shaking, camera is not shaking, so I can control what I want to see. And the tip of my instruments always work parallel with the tissue. And this is very, very good because you can be 1 millimeter wrong in a wrong area. So you can damage a lot of things. And maybe here I was a little bit deep at the right side because I had some bleeding, but sometimes you have some vessels that come from this area. But in fact, we have to avoid to burn too much. Now we will communicate anterior with the lateral side. We go to the right side, you can see the nerves, you can see the traction, and probably we are going to be able to see here where emergent pillar, we have some branch that goes inside of the mesorectum. Now I switch again the camera, I'm working with 30-degree. This is the mid-rectal artery. We are detaching the meso, trying to keep and preserve the emergent pillar. And now we go a little bit posterior. You see the strategy is a little bit different than what we do in laparoscopy. We go posteriorly. I'm gonna jump here a little bit, just probably I'm very close to my time. I'm working at the side, right side. You see the elevators. We go now to the left side. And now you will be able to understand a little bit. Usually, if I follow this plane over here, I'm gonna be too lateral. And this is the mistake that we do when we do laparoscopy. With distraction and communicate anteriorly with posterior plane or the lateral one is more easy to get in the proper plane and to avoid to damage the nerves that cross over here. And now we are detaching from the left side from the elevators. I'm still working with 30-degree. You see, when we do distraction, we are compelled to dissect over here. So, and with this type of traction, we are able to recognize the facial planes. This is why for those who have an opportunity to use this technology, they migrate from laparoscopy or transanal for this type of tool to help us to do our job in a proper way, in a better way. In this very obese patient, is almost mandatory to do that because we know that this type of patient has a very high level of conversion rates and much more than that, incomplete mesorectum. We go further a little bit. This was a very low tumor, needs a very low anastomosis. I'm gonna jump here a little bit because of the time. You see that I'm switch again the camera for 0-degree. I'm working anteriorly at the left side. I like to use this small sponge to help me to grab the tissue and not tear the mesorectum or the planes. And this is the view that we are able to have. Jumping a little bit further, just to show in a very deep and difficult pelvis how we can dissect, and the way that the tips of the instruments adapt to where we want to get in. I'm almost getting to the anal canal over here. Very deep and low, as you can see. The finger of the assistant, maybe this is a drawback, the difficulty to place this taper. And in this system, I don't have the robotic one, but this is something that we can discuss, and well, can discuss about this type of complication. But with the finger inside, we are able to assure the distal margin. One cut. The second one, usually we have 2 cartridges of 45, but do you have also this problem in the laparoscopy surgery? So I'm going to remove this specimen so you can check the pelvis by itself. The dissection, hypogastric nerves, erigent pillar. I'm switching for indocyanine for ICG, but and then this is the how we believe that is the way to standardize and to do robotic surgery using this tool for TME. Sorry about the time, so thank you very much for this opportunity.
Thank you, Armando. So this is robotic, and I have one question because we have 2 other faculty members. Rule, are you doing robotic TME or?
I've done robots in Oxford for a while, 15, 20 procedures, and I think it's definitely better than laparoscopy. But once you've mastered TaTME, I can't see any role for the robot anymore. So for me, robot is better than laparoscopy. But in my hands, TaTME gives me all the tools that I need to tackle any tumor, as low as it is. Obesity is not a problem anymore. But you can see with the robot, you can also do a very nice and well executed dissection. And I can guarantee you, this patient with laparoscopy, it's not going to look pretty. So yeah, robot has benefits, but I think once you've mastered TaTME, that's also an excellent technique.
Okay. Professor Ito, what's your opinion about robotic?
Very good procedure. Thank you for what we can see the very good procedure. But my one question, and belly tumor is close to anorectal junction. Also, tumor is a T3 or T4. So the plane is a little bit difficult to control, even if you perform with the robotic devices. What do you think, Amand?
Well, Masaki, I believe that if you do a good traction, you are able to recognize and doing the planes. The fact is, we have a learning curve for all of the things. I know that you 2 are doing transanal TME, but how many people are doing that and with good results? Unfortunately, we see some papers and some countries that they have very, very bad results. And I believe that individually, surgeons can do things that the majority of the surgeons are not able to do. And I believe that you both are able to do everything by transanal. But because you have wonderful skills and this is the way. When we think about the general population of the surgeons, what they are able to do and how much case they need to pass through the learning curve, this is a different thing. And so, well, I did transanal TME and I published with Joel 2010, and I abandoned the technique, and I don't think that is better than robots. In fact, I really believe that maybe for some cases, selected case, I'm not saying that this technique is not worthy. I'm just saying that we have to select the case. If you have a tumor, maybe 2 or 3 centimeters from dentate line or very close to the anal verge, is a wonderful technique to do transanally. I'm not going to disagree on that. But if you have a tumor located at the low and mid rectum, the minimally invasive tools that we have nowadays, even laparoscopy, you know that I did a lot and doing a lot, can be a good choice for that. But in selected case, very obese, male, as you said, Joel, sometimes it's not feasible to do this by laparoscopy, and robotic can be a good tool.
Okay, this is a subject probably that we discuss at the end after the lecture of Masaki. I'm turning on the side to Madi and Ayaki, because we will see a little bit what's the profile of our participants and get some idea of what they're doing today. So Madi, you have the ground.
Yeah, thank you very much. Yeah, indeed, to talk about the preferences, I think it's good also to listen to what our colleagues in 127 countries do, because they are with us today. Can we show the first poll question, please? And I ask everyone who's watching us through Zoom to answer this question. For a mid-rectal cancer, my procedure of preference is, please choose one of the following, just to see what our colleagues are doing in the world. In the meantime, a question for Dr. Melani. We have asked earlier a question also for colleagues all over the world, asking them what their preference is in general for rectal cancer. And it's surprising to see that 37% still does open TME surgery as the preferred type of surgery. So if they are now about to continue and go to the laparoscopic or robotic surgery, would you say start with the with the laparoscopic first, get some experience and then move on to robotic? Or would you say in that case, robotic is definitely the best, go directly for it, if costs are not an important thing in this case?
You know that I did a lot, yes. You know that I did a lot of laparoscopy TME. And well, if we go for the experience from the US, adoption of minimally invasive surgery for rectal cancer, people jump directly from open to robotic, they are able to pass through the learning curve and do it in a proper way. So I don't think that some basic principles you need to understand laparoscopy, but the technique and the tactical maneuvers inside is very different. And so you need to understand about the pneumoperitoneum. In fact, robotic TME is a telementoring laparoscopy. And so you need to understand a little bit, but you don't need to pass through the curve of laparoscopy to jump for robotic. Not everybody has the robot, and this is a disadvantage. And this is the reality of our world. Unfortunately, even for colon resection, not everybody is doing minimally invasive surgery.
Yeah, I think it's important, and the question probably it's quite similar in the prostate story, because prostate urologists were starting directly with the robots. So maybe we'll have the same phenomenon with rectal surgery. I don't know. We don't know. My question is because we know that 35% are doing open, so it means that the other ones are doing minimal access. So no matter if you have experience in laparoscopy or not, but when you're moving from laparoscopy to robotic surgery, what is 3 major difference in the surgical steps, if there are?
Well, I can tell you that to work in laparoscopy TME, you need a very good camera. You need a very good assistant. In the robot, I don't need. I can control everything. I'm not using my assistant to do any traction. I don't need anybody to help me. I am able to do solo surgery. Yesterday, we have a good discussion in a live from Mariano Jimenez, and Eric Rollier was there, and he surprised me. He said, we did laparoscopy for several years, and I did transano TME, and 2 years ago, I jumped into robotic TME. I can guarantee robotic TME is gonna kill all the techniques. This is Eric Rollier, it's not me. Okay. What I'm saying that this tool is very helpful for the surgeons.
Okay. Interesting, Maddie. We have the results of the poll, so we will see a little bit.
Yes, it's quite interesting. We see them on the screen. So the open TME is still popular, 30%, and the laparoscopic TME is 60%, and then we have the robotic. So
how much robotic? Because 10, we don't have the slide.
10%.
10%. Yeah. That's a lot.
So the good thing is that we have an option. I think that is one of the conclusions that you can draw, and the rest of the discussion we will have in the rest of the presentations. We have a question from the audience, colleague Yuri Mikhaev. Could you please ask your question?
So Yuri, you push on your mic, and our team will allow you the access to the line. Yuri is there?
He is there, but it's there is a problem with the mic, I see. All right, so one final question, if that is possible.
No, from the audience.
From the audience, we can move on to Togo Tobakiar.
Okay, Tokyo, push on your mic. He is there. Go ahead.
You can ask your question.
Where is he? No, he's not there. So I think that we will have time afterwards in the general discussion to get back these guys who are willing to ask questions. Thank you very much, Armando. So I'm really amazed to see that quite a significant number of these participants are using robots. So it's a good sign for you. I'm very pleased, as I was saying initially, to introduce Roland Pes, not only because he's Belgium, but because he's a brilliant surgeon and with very innovative thoughts about the management of the patient intra and postoperatively. So my pleasure to welcome you and give you a lecture on when it goes wrong, dealing with complication during and after rectal surgery. Thank you very much, Roland.
Thank you, Professor Belmagne. Can you see the screen?
No, we can see you.
You can see me, so I have to share it. So thanks very much for the invitation and brilliant video on the robot. But sometimes things don't go as you want them to go, and I will focus on some of intraoperative complication, but I will focus predominantly on after surgery, and particularly the management of anastomotic leakages, as we've developed a sort of a standard pathway for our patients. So intraoperative problems. This is a video so that I got from a UK colleague, and it sort of shows everything what can go wrong when you're trying to take the IMA. And he's got a very big energy device here, which I don't really like, but also you can see that the artery hasn't been cleaned at the back, and that was the first mistake. But if you take a vessel, make certain that you've nicely controlled it. You can even put clips, but definitely don't do this. You can see already when he releases here the energy device, it hasn't fully gone over, and that's sometimes a problem with these energy devices. You have to get fully across it to be certain that you've had full control. And you can see he's got multiple applications here of the energy device. Initially it looks fine, but then he even starts pushing a bit on the recent seal. And as we all know, we should not disturb any seal that we just made. And then during his dissection, you suddenly see some blood coming from the retroperitoneum. So clearly this seal hasn't taken. I think the first thing that he does is good, try to stop it, but then uncontrolled, further trying to apply the energy device. Now we've got a bleed there, and then what you often see, here come the clips. Try to just put some clips over without further dissecting it, and you can see these are these horrible sharp clips, and you can bet you're gonna cause some more damage with these. So he hasn't got any idea where the bleed exactly is coming from, probably the IMA, but he doesn't see the tip. now tries to put a clip on without having any exposure of the area that he's trying to control. And of course, when you do that, you're going to get yourself in more trouble. There, now it starts bleeding a bit more, trying to put another clip on. And the more clips you put there, it's going to become a bit more complicated to get this under control. And these situations, we might have all been, but what to do here, and I think this is a brilliant adagium, which I borrowed from Danila Miskovich, comes from the European School of Coloproctology. You need to, the adagium is start. First thing to do is stop. You stop yourself doing stupid things, but also stop the bleeding. Get a gauze on there, recompose yourself and think, is this something that I'm going to be able to manage myself? Do I have the skills to manage it? Do I need to get another colleague in? You warn your anesthetist, and then you need to think about access. Do I have the access? Do I need to put another port in there to get some suction in there? And then you think about repair. So don't overreact. Don't start doing things that are not useful. Use this adagium, and you can use this for lots of problems intraoperatively. Switching totally gear, we've talked about TaTME. Just want to point out, everyone doing TaTME, you should be aware of this intraoperative complication. It's a CO2 embolism. So we've done a report on it from the National Registry. It sort of seems to be reported, probably underreported at 0.4%. But even in this small cohort of patients, we had 2 patients that were resuscitated on table because of this. So what happens? So here you can see I'm doing a very low intersphincteric approach here. So there's no point in, I can't get a purse string. So this is endoscopic intersphincteric dissection. It's not the point of that, but I sort of blew gas into the colon and I'm putting a tube in to desufflate the colon. And then I sort of let the pressure go because I'm going to try and close this defect. But then suddenly you see bleeding coming that you didn't see before. And that's a venous plexus. And you can see the air bubbles coming back. So you had bleeding while the pressure's going, now the pressure's off. So we've insufflated blood into the venous system, CO2, and now you see the bubbles coming back. This you should not do. You should get a gauze in there and get it under control, as you can see here, because they're usually tangential injuries of the vein. But more important, what my anesthetist didn't tell me, that there was a significant drop of the end-tidal CO2. And your anesthetist needs to be aware of this. And this is another patient that from my time before in Oxford, the first thing that the anesthetist noticed wasn't a drop in the end-tidal CO2, but followed by a complete drop in the blood pressure and saturation because an airlock was initiated in the right ventricle. So if you push in enough CO2, you will get hemodynamic instability. So we've developed a particular protocol to prevent this. So there is a constant line of communication between the surgeon and anesthetist, and definitely the anesthetic team need to be aware of this. During any case of TaTME, particularly if we're doing redo surgery, there's a tighter end-tidal CO2 monitoring, and any change in end-tidal CO2 is mentioned to the surgeon. Because if that occurs, we need to stop immediately all insufflation, particularly also the abdominal insufflation, reduce Trendelenburg, flood the operative field with water, and give the patient 100% oxygen. If there is severe hypertension that sort of suggests there is an airlock there, then you can consider CPR to fracture the embolus. They tend to do that in an esophageal echogram, but again, that's just to sort of note if that embolus is there. And then they can check for a patent foraminal valve, because if that's there, then of course you have the risk of it going to the brain. But this is an important thing to be aware of if you do TaTME. Also with the anastomosis, you have to be aware, so it's a double purse string, single stapled anastomosis. But if you're doing a double purse string, sometimes the tissue that you're taking distally is a bit thicker. And what we've noticed on a few occasions, if the tissue is too thick, particularly in IBD, that the staples are probably not long enough to get across the tissue. You can see me here picking out unformed staples from the anastomosis. And the bleeding of the anastomosis is the first sign there's a problem there. And because the tissue was too thick, it didn't go across, the staples didn't form. And you can see me picking out staples which don't have the standard B shape. So that's your anastomotic leak there, day 0, if you don't notice it and repair it. So another thing to be aware of when you're doing double purse string, single staple anastomosis. And those bring me to the postoperative problem of anastomotic leakages. There's a big distinguish that we have to make between the low leaks in the pelvis, which are usually sealed off, are milder in their clinical consequences, or usually, but can lead to chronic pelvic sepsis. This is completely different from intraperitoneal leakage, where peritonitis can set in, sepsis, and patients are more prone to mortality. How do we manage these? Of course, if you have a phlegmon or an abscess, you can treat this conservatively. An abscess, you can get CT-guided drainage. But in our unit, we try and preserve the anastomosis if the condition of the patient, of course, allows this. And again, you try and do this by laparoscopy or even hand assist if there is an ileus. But try and avoid a laparotomy, because we all know that once the hand goes in, the anastomosis is usually disrupted and you're more likely to end up with an end colostomy. And this is a nice systematic review looking at the feasibility of redo laparoscopic surgery. And in the majority of cases, what they found is that this is, of course, more common if your primary operation was open, but you can also see that across the board, and there's a lot of allocation bias in these studies, but there's a reduction in length of stay, 30-day morbidity, and the study by Venix was actually the largest from this cohort, even showed a significant reduction of mortality. What they further found, again, it was predominantly for anastomotic leakages, and as I mentioned, when you try and go back in laparoscopically, more defunctioning stomas are brought out again. So trying preserving the anastomosis. If you go in open, you're more likely to do a Hartmann's procedure. And we all know the sequela of re-laparotomies. This is what usually happens, and you're less likely to do this when you go back laparoscopically. We're now going to these leakages after low anastomotic leaks. Of course, in our unit, lots of our patients are not diverted because we have got a policy of high selective diversion. Of course, these patients we need to divert, wash out the colon, and then we need to get control of local sepsis. And the majority, you can divide these between passive management, transgluteal, radiological drainage, transanal drainage, and active, proactive managers, as is the standard in our unit. We don't really like passive transanal drainage or transgluteal drainage because we think it's an insufficient and inefficient way to deal with pelvic sepsis. It's more labor intensive. There's no good paradigm to say when you have to stop these irrigations. It usually takes longer to get sepsis under control and the anastomosis to heal, which means more fibrosis, poorer function. And a nice study from the group from Paris, from Jeremy Lefebvre, showed that with using these passive mechanisms, they were only able to preserve the primary anastomosis in half of their patients. So this is our algorithm. We have a post-op algorithm to look for early leaks, and because we don't defunction our patients, we do pick them up quite early on day 3, day 4. And then we start with endosponge treatment of the leaks. And you can see here there's a leak. This is the cavity that's been pre-treated with leak. Well, what we then do, we try and get mucosal approximation. So early surgical closure once you've dealt with the sepsis. Why is that? Once you've got mucosal approximation, the source of sepsis is gone. So again, you restore that anastomosis. It's a shorter, well-defined pathway. It's therefore also more cost effective, and we think it gives better outcomes with also probably better functional outcomes. And here you can see, of course, this defect is difficult to miss, but sometimes the defect can be quite small. But we already know from our CT scan with rectal contrast, there's a problem there. So if you're doing these endoscopies, carefully check for any small sinus and some pointers. Here it does seem fine, but we know there is a cavity behind this anastomosis. So we always do this endoscopically. Don't do this in theater bluntly because you're going to disrupt that anastomosis even more. So here you can see us pushing in gently the endoscope, and then you suddenly see the sepsis that is behind the pouch. This was an ileoanal pouch. And now you can assess that cavity really well. You can rinse it. And then you can also assess how many sponges that need to go in there, because if it's a small defect, you only put in 1. it's a big defect here, like you can see here, and we're rinsing out all the pus here, then you need to put in 2 endosponges. And then once you sort of get that nice granulating cavity, it's time to close the defect. And this is really important, we think. If it's a low-lying defect, you can do this transanally. You always need to put a drain in there, because otherwise you will get a new abscess, and then that can lead to reversed leaks again. And then we take the drain out after 5 days and give the patient a week of oral antibiotics. And here you can see a small leak. So we balloon dilated this leak to get access to the cavity, put in 2 courses of endosponges, which are usually changed every 2-3 days. And then we did the transanal closure with transanal sutures, because the defect was quite low. And you can see from the time that we picked up the leak till mucosal approximation was 10 days. And here you can see the endoscopy picture 2 weeks after transanal closure, nicely healed anastomosis. And we checked that again with a CT scan with rectal contrast. And again, this is a very well-defined pathway. If the defect is higher, as we sort of showed in a video, dynamic manuscript which we published in colorectal disease, you can use the transanal platform. It's not just for TaTME, it's also great to deal with pelvic sepsis. And you can see here the defect, you can see the afferent loop, the efferent loop, you can see the drain here, top right corner, going into the abscess that was pre-treated with the endosponge. And then you can see us putting in these separate sutures, and here you can see the restored defect. What are the results of the CLEAN study, which is a study that was already published in 2017, so very early experience. This is also multi-center, showed that we can get anastomotic healing in 70% of patients, and it's particularly much better outcomes if you start early, before 3 weeks. This is an update of our study, so now more patients in this cohort, and you can restore anastomotic integrity of the primary anastomosis in 80% of patients, as long as you can start early. And if you start later, so well beyond 3 weeks, it's only 60, but you have to remember some of these patients were referred to our unit only a year after they had their anastomotic leak with chronic pelvic sepsis. So you have to start early. And you also have to be aware if there's a fistula present, either to the vagina or perineally or anywhere, then the result of this management is less efficient. If you can't get a mucosal approximation, what to do then? For instance, here where there's significant retraction or even an ischemic colonic conduit, you have to redo this operation. And then you have to look at what the patient condition is, your surgical window, and particularly your own skills, whether you want to take this on as an acute redo or get control of sepsis and redo this procedure a few months later. But it's going to become more difficult. Here you can see a patient of mine is a TaTME, had an internal hernia, so that all the small bowel went underneath the colonic conduit, and he developed a massive leak on postoperative day 4. You can see the defect here, and you can see it on the CT scan with the contrast there. So here we had to go back in, reduce the internal hernia, bring out an ileostomy, wash out the colon, and we put in 2 endosponges. And you can see here how this cavity sort of evolved. You get control of sepsis, you can see that. You can see on far right, you can see nicely granulating tissue, but you can also see the significant retraction. This is not going to resolve itself by putting some transanal sutures in. So you have to redo this procedure. So either you do that later on, but we had the surgical window here. He was operated laparoscopically, so we took the opportunity to go back, and this is postoperative day 17, where we sort of redid the procedure. So laparoscopically, you stick to this colonic conduit. Anterior, it was still attached, we knew that. So posteriorly, we went into the cavity that was treated with the endosponge, and you know you're going to fall into a nicely granulating cavity there. Anteriorly, laparoscopically is going to be difficult. So there we switch back to the transanal platform, where we now have to detach that colonic conduit. So the leak was posterior. So now we detach the colonic conduit from its surroundings. Have to be careful, of course, not to damage anything. All the fat here is not TME tissue anymore, because that was, of course, taken away. This is tissue belonging to the colonic conduit. you refashion that clonic conduit. You can see here how well actually the endosponges have cleaned the pelvic sepsis. And in this patient, we redid an acute coloanal. This was hand sewn. And you can see here the endoscopic picture. So there was a small sinus here, which didn't lead to anything. We cannulated that, and we were able to close his anastomosis 3 months later, and he's got a good functional outcome. So even with full redos, you can get good functional outcomes. So my conclusions for lots of the intraoperative problems, think about the adagium star. Minimally invasive approach is our preferred approach to deal with any type of postoperative intraoperative complications, and think about early proactive management of your anastomotic leaks. Don't walk away from them. Treat them with endosponges and early surgical closure. And for all of these things, know your own skill set. If you can't manage these yourself, try and look for a colleague who can help you, or some experts that can give you some advice. Thank you very much.
Thank you, Roel. I'm really amazed by this presentation that I know a little bit, but the way you're approaching this problem of low fistula is quite interesting, because it's pretty new, and I'm pretty sure that will generate a lot of comments on that. My first question on the general aspect is, I can imagine that you're following very closely your patient in the postoperative period. And I know that you have some parameters that are indicators for a control of the anastomosis. Can you comment on that?
Yeah, so for all low anastomotic anastomosis, as I mentioned, the majority of our patients don't have an ileostomy. So we do routine CRP measurements, day 3, day 4. And if there's any clinical signs or leak, or if the CRP is above a certain threshold, for day 4, for instance, that's 135, then we go for a CT scan with rectal contrast. And if there's a leak, then we go in for this management. If the CT with rectal contrast is fine and we still have our doubts, then we would do an endoscopy to check very carefully if we can see any signs of a leak. In patients that we do bring out an ileostomy, we still check the CRP, but we also bring the patients back 2 weeks after the operation for an endoscopy, because even later on, if there's a leak, we want to start early, because the cutoff is probably 2-3 weeks to get a good outcome with the management of endosponge. And this is also from a French study from the Rectal group. They saw much better outcomes when patients were treated within 2 weeks after their index surgery.
I'm not an expert, so I will ask to the experts. Armando, what is maybe you're following this, the same scenario for the management of your low leak, if you have some. But what is your attitude regarding that? What are your thoughts about this approach?
Well, congratulate Roel. This is very innovative, but I have some concerns related to that, because the problem is not the leak by itself, but the fibrosis that patient is gonna lost a lot of functional results related to the fibrosis of the pelvis and the muscles. And this is why, well, sometimes the patients ask to avoid ileostomy. I always regret when I do that, because when I have a leak, I have to do the ileostomy 3 days later. And we also do RCP for our patients, but unfortunately, the RCP rise 24 hours after the problem. And so you are gonna detect this a little bit late. If you don't put your finger every day inside of the anus of the patient, I don't know how to control that. And there is another thing, using endosponge, your patient stay very longer into the hospital. Maybe in the public system, you can do that. I don't know, from the papers, well, they used to say that patient need to do 30 days inside of the hospital with endosponge, and sometimes 60 days using endosponge, and you have to change every 3 days, 3 or 4 days. And so in a public health system, maybe it can work, but in a private system, is very difficult to manage that. I believe this is very innovative, and I know that you do one thing more, and you didn't told us that you over suture now your anastomosis. Is that correct? you overswing your anastomosis. You don't trust in the staples by itself. You overswing your anastomosis.
Yeah,
And leaks is a very hot topic for us, because we have it, and it's very complicated when we have it, and I believe that the new things to avoid ileostomies is a good strategy, but we have to go very careful on that.
But just one comment on that. So I think what's been seen in the literature with the long use of the endosponge, that's the old technique, the old Weidenhagen technique, where they put in endosponges until the cavity granulated until it was only a centimeter deep. That's why we think you need to do this with early surgical closure. So endosponge, and then once the cavity is ready, it only takes 2-3 endosponge changes usually, you close the defect. And this patient that I just showed with the closure in 10 days, that patient is at home, because if he has his ileostomy and he's doing clinically well, he can go home, they come back in as an ambulatory patient to have their endosponge changes, and then they come back in to have their transanal closure. So they're not in for 60 days, they're in for a shorter period of time. And again, lots of surgeons think that with an ileostomy, the leak rates go down, your acute leak rate goes down, but as we've shown in the Netherlands, when you look long-term, the leak rate is exactly the same, but there exactly you're gonna have the problem as you alluded to. Then this is when you get the chronic functional problems, because with the late leaks, they've been leaking from day 3, day 4, you just didn't see it because you have an ileostomy there, and then you have chronic pelvic sepsis. And that has a much bigger impact on functional outcomes. We did this for our pouch patients. With pouches, of course, are not radiated. We've got 100% success rate of closure. We looked at functional outcomes, and we haven't seen any detrimental functional outcomes in our pouch patients that are treated with endosponge after an anastomotic leak. So it's again a novel treatment pathway that you need to get used to. But I think to manage leaks, it is really changed our practice.
Well, I'm very excited, Bernard. I want to interact with him. I'm very excited about that. And maybe we are speaking about different type of patient. Unfortunately, the majority of my patients, they are irradiated. So, and this can be a problem. And in the other hand, we know that ileostomy does not change the leak rate, but decrease the pelvic sepsis. And this is the problem, the fibrosis related to that, the functional results. And maybe when you have your functional results of those patients with very early management of the leaks, maybe we can understand how is the real whole of this technique and innovative one in the function of these patients, because this is what we are worried about. We now control the cancer. We have a very low rates of local recurrence, and we have to think about functional results. And this and probably this is the way to go. And I would like to avoid ileostomy in the majority of my patients. Because I would like to do that.
Because we also know that bringing out an ileostomy, there's now lots of evidence coming out, and we're gonna publish a systematic review on the literature on this. If you bring out an ileostomy, that already has a detrimental impact on patients' functional outcomes. So we know that patients with ileostomies, their functional outcomes are significantly worse than those who don't have an ileostomy from the outset.
Yeah. Interesting point, Roel, because yesterday we addressed this issue during one of the talk, and that's something that is important also. So I understand, but I think it's important to watch a little bit the results of our friend in Holland, in Amsterdam, because I think it's something that is new and very promising and changing a little bit the philosophy of the leak. Interesting not only for rectal surgery, but also for the types of anastomos. So we have to watch closely the evolution of your results. So I'm going to Madi. Madi, if there are some questions from the audience, or
Yes, we have a couple of questions from the audience. I would like to move a bit from the anastomotic leaks to other things that we can damage during surgery. One of the question was, what do you do when you damage the prostate? And in extension also, what do you do with the urethra? And I know you have some work about that too.
So hands touching wood, I've never injured the urethra, fortunately enough, during TaTME. I've seen plenty of videos while it occurs. I think the only thing you can do at that stage when you injure the urethra is to suture it. You have to get a catheter in, and depending on how big the defect that you made, you have to sort of repair it. And the transanal approach is a very good way to repair it. But that's the only thing that you can do then at that stage. Getting into the prostate, I think it's an issue that we had early on because we were learning the planes, and I think Masaaki Ito will discuss that. But nowadays, I rarely find myself into that wrong plane, particularly anteriorly. Sometimes when you start really low down intersphincterically, you sometimes tend to get a little bit too anterolaterally. But there you have to look for signs, and any bleeding in TaTME is a sign you're in the wrong plane. So we don't use any energy devices because that masks any bleeding. So we use monopolar energy. And if you've got a bleeding in TaTME, you're not in the wrong plane. You have to stop and reassess. But getting into the prostate, that never has happened to me, I must say, because it's sort of a different type of tissue. But again, it's looking for the signs. Go slow initially. Look at the angles that your instruments are taking when you go from transanal. But again, that is learning curve.
okay, you have question from the audience?
There is a
last question. Yeah.
Exactly, a raised hand. Maybe you can try colleague Rodrigo to ask the question live.
Rodrigo
Nuevo.
He's gone.
He's gone. All right. So maybe a short question, which is also popular here. Also during surgery, what to do when you perforate the tumor? What are your recommendations?
When you perforate the tumor, that's bad. Well, I think you need to close that defect if you can to avoid any further tumor soiling, and then very carefully irrigate that area with any tumoricidal agent that you have. That is one of the concerns that we had with TaTME, because of course you're sort of opening that operative field. You've got a big raw area where you might have had, particularly if your purse string is not tight, that you can have tumor soiling there. That's why we now advocate to do a double purse string once you've done the rectotomy. But again, the only thing that you can do then is to close that, irrigate that area with a tumoricidal, and try and avoid any further damage to that area. But that's a bad situation. And that patient is, of course, going to be at risk of local recurrence. So you have to really carefully monitor him in the post-operative period.
Armando, you have some tricks for that? Because I guess that even in TME, sometimes for people who are not very familiar with TME sometimes, or Bellevue tumor or fixed tumor, or whatever, that can occur. So Armando, what would you recommend in this situation?
I never saw by myself rupture of the TME in a tumor TME, besides if it's a T4 attached to some pelvic structures. And so I believe the majority of the problem it is related to the beginning of the transanal anterior plane, where you can perforate the rectum, because when you are dissecting in between the rectum and the urethra, you don't know very well where you have to go, and this can be a problem, and you can perforate it. I believe that if you can suture is a good idea, but you have a T4, you are changing the prognosis of your patient, and this is true. And unfortunately, this is very, very bad. So it's a nightmare situation.
Masaki, you have some strategy when sometimes that problem can
Yes.
occur?
As Armando told us, the anterior side is a very risky area, but also the posterior side. Maybe when you start the transcendental TME, rectal dissection is also the problem because very close to the anorectal junction, there are very little amount of the fat only. So sometimes go to very close to the rectal wall. So just we need to dissect along the endopelvic fascia. So we should take care of the not only anterior side but also posterior side. Is also we should take care of the selection of the dissection plane.
But if you have a perforation, what is your recommendation? I mean, tell to people, because we're
Yes.
talking about TaTME because you're expert, but
Mhm.
you've seen that
Yeah.
the majority of our participants are not experts.
Yeah.
So they're
Yeah.
probably still doing some formal TME.
Mhm.
And we
Yes.
know that tumor perforation is reported.
Yes.
So it
Yes.
exists. So
Yes.
what is your recommendation? You are doing either TaTME or TME, and
Mhm.
you have a perforation. So what is your recommendation?
Yes.
Should
Most
we
important
open the
thing.
patient? Does it change
Yeah.
the outcome?
Mhm. So most important thing is that immediately close our injury perforated area is most important thing. Second is much luggage and to diminish the cancer cells in the leakage area. And also we cannot such a procedure. We push and cover some gauze and pushing and place leakage area.
Okay, that's good. Good to know because
Bernard,
we know that it exists.
Bernard, just one thing that, well, this type of patients with a very big tumor, usually we radiate and we have this shrink of the tumor in the majority of the case. It facilitates to keep the plane. In the other hand, when you have something attached, you have to understand that you have to change your plane. You don't go in the regular TME plane. You have to change your plane to go outside of the regular TME plane if you have a very huge tumor attached to something to avoid perforation. And maybe the MRI preoperative can help you to determine the strategy before you go to the surgery. I believe this is probably the best way to avoid it.
Okay, my question was, I'm doing laparoscopic TME. I have this problem because I've not a huge experience, or I have some technical problems. I don't know. So, to all of you, should I open my patient to better clean or better control, or should I continue by laparoscopy? That's a question, probably.
I think that's a good one. And I must say, the times that I've converted from laparoscopy open, it even got more difficult because usually you're in a tricky spot, and then to open it not always is going to make it easier. As I mentioned before, and as Massimo also said, getting control of the defect if you can by suturing it or putting a gauze against it and washing it, and then trying to complete the procedure as good as possible. If you're not progressing laparoscopically, you might have to open, but usually in that circumstance, it's not going to become an easier operation at that time point. You've also actually compromised the oncological outcome of that patient. We know that.
Armando?
Well,
Contact?
I agree with well, and of course, if you put your hand, you can contaminate more than you and spill. They have more spillage of the cells instead of working with 5 mm instruments where you touch specific areas. So washing and closing is the best way. If you can progress by laparoscopy, probably is the best way. But
Masaki?
if you are in the trouble, you don't understand what's going on, well, you have to open. If you are confident with open surgery, you have to open. I believe there's a variation among the skills of the surgeon to continue or not to continue. You have to be comfortable and try to achieve the best mesorectum that you have it.
Okay. Masaki, what's your
Basically,
recommendation?
I agree with Amanda's opinion, but depend on the perforated site. So if we feel some difficulty in closing the defect, so conversion is sometimes mandatory.
Okay, this is a very nice discussion after this Brian lecture of rule, because that raises question for the audience. Again, we have to think not only on in discussion between experts, but also to imagine the life of all the participants who have different level of expertise. So I think that the message that you're giving are very, very important. So time is passing, and we will move to the next talk. And again, this is my pleasure to have. I've seen him in IRCAD, so I know what he's doing. So that's why I choose him, because I was amazed by the technique of TaTME. So I know that he knows TaTME, but my question, as I was mentioning earlier, is does it make sense to focus still on TaTME, because we've seen the reaction of some countries or some centers of whatever, saying that there are still some doubt about the value and of the TaTME. So this is why I asked to the expert to give us his feeling about this discussion about TaTME. So thank you for being with us.
Okay, Chairman, can you watch my video slides? Okay, so my topic is TaTME. Where do we stand? So I understand that transcranial TME is not easy procedure for rectal cancer surgery. So we need to some learning term to get the skillful technique. So as all you know, the TME is gold standard, and the TME plane, which is a very embryological plane, is very essential to keep the correct plane. However, there are some limitations in performing the TME. One is the CRM. So a very high quality clinical trial shows positive CRM is around 5 to 10% is still remaining. And also, sometimes we feel the very difficulty in cutting, transecting the rectum. And sometimes we experience the shortage of the distal margin and multiple firings ending up to the anesthetic leakage. And potential nerve damage is also important. So that even if we perform laparoscopic surgery, but sometimes, especially in neurovascular area, so we sometimes very approaching to the nerve side. So we experienced urinary dysfunction after TME. So TME, TaTME is one of the innovation for the rectal cancer treatment. So we can, greatest merit is we can see those we could not see from above, and whole round visibility across the entire circumference, and also straight dissection is can be done. So no need using multiple joint forceps. So this is a very important anatomical issues. So if you start the transcranial TME, this relationship of the very important structure is you need to understand. So anorectal junction and the dentate line and the anal verge. So usually we have the 3 to 5 centimeter of the anal canal. And if the tumor is here, so it should be judged 1 centimeter from the anorectal junction and 5 centimeter from the anal verge. So, and one of the very greatest merit in the performing TaTME is we can understand to establish the step-by-step procedure. And we divided whole procedure into the 9 steps. In the first place, bursting suture. So as you know, the last year, we can get some important result from Norwegian. So after TaTME, about 10% of the local recurrence. And this pattern is rapid and multifocal growth. Maybe I think that this is a shortage of the scale of the pulsing suture. And this pulsing suture technique is very important before starting this TaTME technique. So I'd like to explain the pulsing suture technique. So I place the gauze at the very close to the tumor, and start from 1 o'clock, and don't deep suture deeply as a guide to apply to the submucosal layer, and no gap. So gap is sometimes causes the cancer leakage. And also, this is the first pulsing suture. And after some dissection, after performing the rectotomy, recently I must perform the double pulsing suture. So next, rectotomy. So you could see the figure. So around the rectum, so longitudinal muscle fiber is a very key anatomical structure in performing the safe TaTME. So you can see this longitudinal fiber is going to outside and attached to the endopelvic fascia. So I'd like to show the video of rectotomy. So after making the pulsing suture, so we checked this is completely done. And then, I'm cutting the circular muscle, and you can see the longitudinal muscle, and the 1 o'clock is a very little amount of the longitudinal muscle, and enter the very good space, and the 11 o'clock is the same. So 0 o'clock is a little bit thick longitudinal muscle fiber, which is called as rectal urethral muscle. So we cut this fiber and entering the back of the prostate. And in the posterior side, also 5 o'clock and 7 o'clock and 6 o'clock is there are coccygeal muscle, which is a little bit thicker muscle. And now we are cutting this white smooth muscle, and we can enter the very good space of the TME. In posterior side, it's a little bit difficult because in usual laparoscopic approach, there are 3 dissection plane from above. And so the figure shows 3 planes such as ABC. And but in a transcendental TME, it's an area close to the anorectal junction. There are 2 dissection planes from below. Because of the at the point of the rectosacral fascia called or the Wardaia fascia, mesorectum and the prehypogastric nerve fascia is attaching to the endopelvic fascia. So the little bit the dissection is a little bit different from above and below. So I'd like to show the posterior dissection. So this is 5 o'clock. I'm dissecting into the plane. So and this patient is the T2 case. So we intentionally select the dissection plane above the endopelvic fascia. This is a usual plane, like the usual laparoscopic plane is there. And so you can see some contraction is, you could see. So contraction means monopolar cautery very attaching to close to the levator inner muscle, and very gently dissecting along the endopelvic fascia like this. So this is the posterior side that TME planes a little bit narrow, so meticulously dissect along the endopelvic fascia like this. But sometimes, sometimes tumor is a little bit advanced side, such as the T3 or T4. So we need to secure the enough CRM. So in such a case, I'd like to intentionally select the plane below the endopelvic fascia. So in such a case, I intentionally enter the deeper plane like this. Deeper plane means dissect along the levator muscle. So once entering this plane, the specimen was covered by endopelvic fascia. So this is very important to keep the oncologically. So in the posterior side, we could see the some part of the smooth muscle like this. And intentionally, we select below the endopelvic fascia like this. So anterior side, so after cutting the rectal urethral muscle, so enter the plane behind the prostate, and we meet the adenovasal fascia next. So adenovasal fascia is attaching to the upper edge of the prostate like this. So now I am cutting the endopelvic fascia here. So you can see the some hole here. So the after cutting this adenovasal fascia, we are approaching to next space. Next space mean behind the seminal vesicle here. So the dissection allowed to approach to the peritoneal reflex here. So in continue to dissect in the posterior side, we meet the Wardaya fascia. So we need to cut the Wardaya fascia. So you can see the cutting line of the rectal sacral fascia or Wardaya fascia. After cutting this fascia, so dissection direction is not going straight because of which is approaching to the sacral vein. So we need to cut, dissect down to up direction in here. So now I'm cutting the some rectal sacral fascia. So you can see some hole, and then we enter the so-called the B layer, so that very close to the TME plane. But dissection direction is down to up. Don't go straight. Straight dissection sometimes injury the vein here. So lateral dissection, neurovascular dissection is also important. So one of the greatest merit in the performing the transcranial TME is we could see these autonomic nerve systems, including the neurovascular bundle, pelvic plexus, and some pelvic splanchnic nerves, we can see very clearly. So green line shows dissection, usual TME dissection plane. But if we enter a little bit deep below the endopelvic fascia, sometimes approaching to the pelvic splanchnic nerve is ending up to some nerve injury. So we could see neurovascular bundle in upper figure, and fourth or third pelvic splanchnic nerve is more visible from below like this. And we can judge the how amount of the nerve was damaged or not. So if we perform transcranial TME and judged as whole preservation of autonomic nerve system from below, so very few percent of the patient going to the urinary dysfunction. So this fourth pelvic splanchnic identification is also important to enter the lateral space. Lateral space means that we to perform the transanal lateral lymph node dissection like this. So we are cutting the endophilic fascia from below, and we can see the fat. This fat is lateral lymph nodes, and we could see the obturator vessels and the nerve is here. So this structure is very close from the anal junction. And continue to dissect, and we could see the very good plane from below, and whole totally the lateral lymph node was removed like this. So this is completely dissected and preserving the obturator nerve here. And we should dissect one teams or two teams. So I prefer to perform the two teams procedure. So one of the greatest merit is a greatly shorten the operative time. So in performing the usual TME, operating time is 2.5 hours. But sometimes 5 more doctor is needed. This is a very issues to be discussed. And finally, the very one of the merit in the performing the TaTME is anastomosis. So in the early phase of the performing in TaTME for me, so Hansoon and staple anastomosis borderline is, I think, 2 or 3 centimeters from the anal-lateral junction. But recently, my procedure is changing to lower. So the stapler anastomosis is widely performed for me. So this is a closure from the edge of the rectal stump from below. So this technique is a little bit technical demanding. So you need to learn the learning and closure the distal stump like this. So the place some tube and guide the circular devices and pushing to the abdominal cavity like this. So we are no need to distal dissection in rectum, and docking in the sometimes a little bit difficult. I agree, but like this, very clearly the perform the double pursuing suture technique, and we always, if I can, do the reinforced suture on the stapler line from below. So after making the stapler anastomosis and checking the donuts, and I like to make the reinforced suture like this on the stapler line. So this type of pursing suture is no dock here and no multiple firing, no need for distal mobilization of the rectum. And actually, our leakage rate reduced from 7% to 3%. So these to learn the step-by-step procedure, we invented the surgical training simulator like this.
カメラを挿入いたします。
This, if you use this model, so you can train the whole step of the transanal TME. So you can see the rectal coccygeal muscle and the pursing suture was done, and lateral dissection. And this red structure is a neurovascular bundle, and the nervous fascia is cutted and enters the next space. And finally, the this pursing suture is performed, and docking and checking the donuts, and finally we perform the Hansen suture. So in the current status, we have 3 options for rectal cancer. I agree. So a man performed very brilliant robotic surgery, but I think the lab and the robotic surgery is just approach from above. Very similar. TaTME is a little bit different approach from below, but lab and robotic is different. The devices. Lab is used with laparoscopic devices, robotic surgery with robotic devices. And the current TME was used with laparoscopic device. In the future, surgical option is here. Maybe we have two directions of surgery, from above and from below. So in the future, so robotic transcranial TME will be added. Thank you very much.
Thank you very much for this outstanding presentation of the TaTME. So when we're seeing this image, it's a very challenging and very appealing technique. We know that there is still some issues regarding that, and I think that rule is involved a little bit in the, at least in Europe, the problem of TaTME, who should do it, who shouldn't do it. So can you comment a little bit why there are some concerns regarding this technique? Is it because it's difficult? Is it because it's dangerous? Is it because of the patient, the outcome of the patient, or the long-term results? So what are the concerns regarding the TaTME in Europe, at least?
I think a lot of you. Oh, sorry.
Okay. Well, so we cannot get the long-term oncological result now, but this technique is allowed us very good visibility. We can see the very good nerves, and which may be the good preservation of the urinary or sexual function, and anastomotic way of the double pulsing suture is very, I think that will be the reduced anastomotic leakage. So, okay. But long-term oncological result, we will be get the result from the CARA3 trial.
But my philosophy in surgery is to try to allow as much as possible people who can do good surgery. So that's why we have experts, it's evident, for special situation, but we have the range of the surgeon. And the range of the surgeon should be able to perform as well as the experts. This is really the goal of surgery and the goal of our education to the young generation. So we know that there are some problems with TaTME, and that's my question to Ro, to say, what's the problem today with TaTME?
I think the problem today is that we don't have a structured training pathway in place. No one can get onto the robot without going through a structured training pathway. That's controlled by predominantly one company. You have to do an online course. You have to do a cadaver course. You have to get a proctor in place. First you go to his hospital, then he comes to you, and then you do your first cases. And you don't start with rectal surgery. You start with colonic surgery, and then you go to the rectum. So there is a very defined training pathway. And unfortunately, with TaTME, and perhaps we were guilty of that at the beginning by doing too many courses, there's no structured pathway. Any fool can use this tool to do this operation, okay, without any training if necessary. And that's the issue. I'm not saying they're fools in Norway, not at all. But if you look at that publication that they reported with 10% local recurrence, their CRM positivity rate is 16%. Who has that CRM positivity rate? We don't see that in any of the larger trials. There we just talked about tumor perforation. They had 7 tumor perforations. I never had a tumor perforation with TaTME. And they did Hartmann's procedure. I don't even know how to do a Hartmann's procedure with TaTME. So I think that training was poor, the execution was poor, and now we're sort of condemning a technique because it was executed poorly. Well, let's go back a little bit into history. What did we see with laparoscopic cholecystectomy? Now it's the standard of care. It used to cause major common bile duct injuries. And we also know that that sort of doesn't prolong a patient's life. Similarly with laparoscopic colon surgery, we had all the port site metastases. A very good technique, executed poorly, will give you poor results. So do I believe TaTME is for everyone? And I have to agree there with Professor Milani. I don't think so. I think if you look at, and I'm being honest here now, if you look at a group of surgeons with certain skills, will it be easier for them to implement robotic surgery? I have to say yes. Do I think robot solves all the issues? I don't think so. So I think TaTME is a brilliant platform, but it is technically very challenging, and you have to really train yourself to do this well, and you have to have the volume. But not everyone is going to be able to buy himself a robot. And so far, and that's the problem, and that's some of the bad press that I sometimes get, that we are bringing out too much negativity about the transanal approach. But at least we have a registry. We are recording these problems. Let the robot surgeons show me their registry. Where is the International Robot Registry? Where is the data from robots and low volume centers? Where is the data from robots being done by surgeons who are not doing an excellent dissection as Professor Milani? There's no data as such. We are showing this, but that's my problem with the robotic community. They don't publish results of small centers. It's only
that's a very, very interesting comment, and I think you're totally right. You stress the fact that for any kind of surgery, training is a major issue, and when you're coming to very complex anatomical dissection, etc., it's even better to go back to the cadavers and train on cadavers before going to surgery. And we know that a lot of people, because they've seen nice video, are starting the next morning to do a transanal, and it's evident that the results will be quite poor. So I think it's a good summary of the current situation. But I will ask to Maddie to run a poll just in our participants to see a little bit where we're standing with this different approach.
Yeah, exactly. We just want to see the dissemination of this technique in the world. And the question is very simple. In my hospital, we do a TaTME procedure, yes or no? Or maybe we did, but not anymore. We are interested to see the answers about that.
So
Bernard,
yeah.
I just want to do a comment related to the learning pathway, if I can. What is really funny, and I believe that I can agree with Joel and Masaki related to that, because the course by itself does not allow you to do the surgery. You need to be proctored. And this is what robotic surgery is the same. And the Brazilian Society is creating a pathway now for training in robotic surgery, because people that are console certificate, they believe that they are able to operate, and this is not true. You have to be proctored. And what means proctoring? Proctoring is almost return back to your residence program. Someone with more experience than you is gonna help you to pass through the learning curve in a baby very fast way. And I believe probably this is the way to go. And it doesn't matter the technique, laparoscopy, transanal, or robotic. And this is the way to go, I believe so.
So thank you, Armando. It's very important because IRCAD is there for training. So thank you for sending the message. But I think that Neraki wants to ask a question to Professor Masaki.
Thank you, Professor Ito. Thank you for your great presentation. I'd like to ask some question. At yesterday's seminar, some participants had a question about the margin from cancer. So there is some different depends on the countries or facilities. So do you have the definition of the distal margin or the radial margin from cancer?
In terms of the CRM, so many evidence we can get. So the 1 millimeter of CRM is mandatory, especially without chemoradiotherapy. So I think if a patient receives the chemoradiotherapy, maybe the 1 millimeter of CRM is needed. And transanal approach is a little bit very easy to get circumferential CRM, because we can select the plane we can see the position of tumor. And as for the distal margin, so Japan's criteria maybe a little bit different, but 2 centimeter of distal margin should be needed in performed for the low rectal cancer. But because we are traditionally the very low rate of the chemoradiotherapy for low rectal cancer, and if we perform the chemoradiotherapy before surgery, maybe 1 centimeter of distal margin is maybe our recent criteria.
Okay, thank you very much, Madi.
Yes, we can show the results of the short poll we just asked. 18% does a TaTME, so that's 18% in the world. Yeah, it's I think quite impressive in the time that we are doing a TaTME. I give the floor back to you.
Yes, it's quite interesting. I just want to ask back to Madi if we have some people from the audience who want to ask a question.
Yes, we have 2 colleagues who want to ask the question. It's a nice name, Adedapo Osinowo. You can ask your question live, please.
Okay. So
sometimes it's difficult. We can try. If not,
hello. Good morning. Good afternoon.
Hello. Good afternoon.
Good afternoon. I'm from Nigeria. I'm from Lagos, Nigeria.
Okay.
We don't even do robotic surgery in my country. So therein lies a question: how do I get to learn a TaTME? We don't do robotic surgery. The nearest we do to minimally invasive is laparoscopic surgery, and most of our tumors are quite advanced. So at times we can't even do it laparoscopically. We still have to do open. So how do I get to learn how to do a TaTME?
So that's a question for Masaki.
Yeah.
This maybe depend on the experience or learning. So if the Amando maybe say the robot is superior, but I think if the tumor is advanced side, so 2 teams approach is very helpful for us. So they especially in the transcranial approach, we could select a little bit the deeper plane, which is covered the tumor by the end break fascia, and we could enter in the lateral pelvic space to get more enough margin. And 2 teams approach is we could support them each by 2 teams and checking, and we can discuss which dissection plane is good or not by 2 teams. So I think as for my opinion, the 2 teams approach is the best approach, is my opinion.
Armando.
Well, until 2014, I couldn't get a robot also. So we used to do laparoscopy and transanal. And I believe that depending where you are, because it's
in Nigeria.
Well, in Nigeria, I believe that you are able to do laparoscopy. For transanal, you need the best device is a disposable one. And in my humble opinion, maybe I can speak better for you. Well, you can do some courses, but the most important thing is to get someone to go down to Nigeria to help you to start your cases. If you don't have that, if you don't have that, well, you have to do open. And so you have to treat the patient. And this is not a problem because you are treating the patient. So there is, Masaki said that I say that robot is the best way. It depends on where you are. If you don't have the robot, the robotics is not the best way. So you have to deal with the situation and the team. I am working with 1 guy only. Masaki probably has 10 people to help him, 2 teams, and so I don't have it. And it's a different reality. And maybe you are also working alone. So how can you get two teams to working in Nigeria? So this is, you have to understand the situations.
So Raul, same question, this large bulky tumor, probably no robot. You are in Nigeria, what are you doing? What are you recommending?
Yeah, don't do TaTME because you don't want this as your first case. You know, you need to get through a learning curve first. It's great, as Masaki said, for going outside the planes and getting extra margins. But then you already have done plenty before you should tackle those, because otherwise you're gonna get yourself into major troubles on the sidewall. And don't forget, we see TaTME as a new procedure. Well, we only added the endoscopic part. We've been doing TATAs for a long time, coming from above. And for the difficult distal bit, you can do this perfectly open with standard retractors. It's the exact same dissection, and you get the benefits that you can get with TaTME also. So my recommendation to you would be to don't embark on this without proper training. If you're going to do this, you need to have a training pathway, and as Professor Malani said, that would mean a course, cadaveric course, and proctoring off-site and on-site.
Excellent. You have another question?
Yes, we have a final question, I think, considering the time, from colleague Mohammed Imran.
Mohammed.
You can ask your question.
Right. Thank you very much. It was a nice presentation by both the presenters. And I'm from Pakistan, Lahore. My question is, what is the learning curve for TaTME? And what are the centers that we can get training, proper training by enrolling, and what is the procedure?
Okay,
Yes.
who's answering?
As Royal also commented, learning curve is very
Yes.
important. So the learning step is very important. So I agree. So I think that in the first place, in the early phase of the learning curve, so we only selecting the case with T1 or T2 and female and easy case. So the advanced case is after getting the experience hand. So the maybe I think that at least 50 around 50 case is needed to get the standard of transcranial TME. In that time to getting the skill, I think that we should select the case not advanced side, early case. And a female is a little bit easier compared to male. And this selection is very important, and also the mentoring system. So the some mentors should be, you can get the mentoring system from expert.
I think that the question was also, where can I get this training? And I think that there are different centers, and Raul probably will comment, at least for Europe. There are some in Brazil also, where you can get this experience with a formal courses, educational program on TaTME, working on models, simulation, then going progressively to cadavers. So I think that it exists. I know that it exists in Amsterdam, it exists in Brazil, it exists in Japan. So you have probably a lot of different possibilities. The only question that I will ask to Raul is that, okay, I'm spending 1 week in a course on the cadaver, etc., to learn TaTME. What's next when I'm coming back to home? Should I start immediately, or should I try to bring someone to help me? So this is the important question.
I think, yeah, you should have someone there to help you with the first few cases, and ideally someone who can be hands-on, who can get you through a difficult part if you struggle. This is something that we've done in the Netherlands, but also tried to implement in the UK with a formal training program. So, and the problem sometimes is that people go to a course and then they've got a first case lined up 2-3 months after that course. Well, then the impact of that course is less valid. So you really have to already have some cases lined up. And a great way to start would be for IBD patients if you have that practice. Okay, so with IBD, you can choose to go close rectal, but you can get yourself acquainted with the platform and doing the section a bit. But ideally, you would have a case already lined up within the first few weeks after the training course with a proctor coming to your center to help you. And I guess as Masaki said, the purse string is crucial for this procedure. If you screw that up, the rest of the procedure is not going to go well. And this is something that you can train on any endo trainer, just suturing in a circle and maintaining that line, and don't scramble up and take the right depth of the sutures.
Excellent recommendation. And I think that Armando and Melanie has also addressed the problem of robotics, saying that in Brazil, they're developing this cursus for robotic surgery. So it means when you're looking at different countries, there are a lot of initiatives trying to reprocess all the educational program regarding this advanced technique or technology. This is very important. So never start the next morning what you've seen on a nice video on YouTube. This is not surgery. That's not fair for the patient. So I just want to go back to Maddie. If there is only one single question from the audience.
Yes, it's a question that I'm going to read because it's a short question, because we've been talking about the TaTME, the robotic TME, the laparoscopic TME. Question is, what about abdominal perineal resection? Is that a thing of the past?
Oof, that's I think the subject for another discussion, because we are running late. So yeah. Prepare yourself for the next. So you will have to answer this question. But we're starting a lot of discussion. So I don't think that we have time for that, because we already spent a good time. So I would like to thank you very much, because this is very interesting. This is very challenging. I think that you have delivered all the important message for the community in general, meaning all different levels of expertise and knowledge. And this is really the aim of this sort of discussion live, is really to deliver this message. So I thank you very, very much for being with us and providing this information for the participant. Thank you, and hope to see you soon back somewhere in IRCAD, live, face-to-face, and not through this web transmission. Have a good time.
Thank you very much.
Thank you, Bernard.
Thank you very much.
Lógico. Não, só sobre o guardamento de batismo.